this is a very special Grand Rounds. I'm going to share my screen for a second and tell you about the history of this. So 3 years ago, 2017, we decided we ought to have a different kind of theme and have one Grand Rounds a year that really talked about what it was like to be a doctor from different perspectives. And one of the very eloquent speakers at that session was Dr. Gary Wahl. Many of you might remember Dr. Wahl. He was a pulmonary and critical care physician, was already here when I joined the faculty in 1988. I think he had joined just a few years before that, and was well known for the human touch in his care for patients. Unfortunately, Dr. Wahl passed away several months after this presentation. This video, the YouTube video of this presentation went viral afterwards, and there were tons and tons of people asking me for it. This was a time when we were not taping these as regularly as we are now. But we did procure the tape, and I think a number of people on the medical staff enjoyed viewing it. And then last year, we decided we wanted to make this a theme. And this was actually Paul Bernstein's idea. Paul was going to be on and be listening, so hopefully he's in the audience watching this as well. This was his idea, that we create a theme on being a doctor, and this theme be in memory of Dr. Gary Wahl, who did the first presentation on this. So this will be an annual theme. Gary's family has been invited to this as well. I can't really see the audience, but I hope they're able to be on and attend and perhaps comment. The format is going to be similar to our format for Grand Rounds, which is only the panelists can use audio and video. The Q&A section of the comments should be used to comment, and I will look at that and try to bring that into the discussion at appropriate times. And then we may try at the very end to just open up everything so other people can speak and comment. We'll see how that goes. So I want to thank Dr. Gaby Razzouk, because he really took the initiative to plan this year's talks. He invited the speakers, set up the theme, and so I'm going to let him take over and introduce the speakers and get into each of the talks. There will be 4 speakers. So, Gaby.
Good morning. Thank you, Dr. Phatak, for the introduction. Thank you, Dr. Bernstein, for passing the baton to me. It's such an honor. Thank you for the Wahl family, for all the speakers and all the audience today. I believe this is our 3rd Humanities in Medicine Grand Round, Dr. Gary Wahl Memorial on being a doctor. We have 4 fine speakers today. We are going to start with Dr. Waqas Tahir, who is a physician blogger, a graduate from our internal medicine residency program, and a hospitalist. Our second speaker would be Dr. Tarilate Aroriode, who actually joined our internal medicine residency program as a 2nd year from Brookdale. Brookdale is in New York, where we heard stories of sacrifice and triumph during the COVID-19 peak that resonated throughout our country. Thank you for being with us. Our next speaker will be Dr. Olga Vasylyeva. She's going to be, or she's actually the program director of the Infectious Disease Fellowship program starting this summer. Also, thank you for being with us. Our last speaker does not need much of an introduction. Dr. Hiloni Bhavsar, our Chief Quality Officer. Thank you. We'll start with Dr. Tahir.
Good morning, everyone, and thank you for tuning in today. I really wish I could see all of you listening to this grand rounds, but we are doing the best that we can with what we have. So before I begin, I would like to ask all of you a question. There's no poll. You don't have to raise your hands or anything. Just answer it for yourself to yourself. Do you ever cry at work? Crying is simply a form of expression of human emotions. We express all kinds of emotions at work. We give smiles to strangers for no reason while we are sharing elevator with them. We laugh at the funny dictation typos, which sometimes make an 87-year-old and only 7-year-old with history of COPD from heavy smoking. We show anger and frustration when we are in a rush, but we have to first log into a workstation and we want to really punch into the screen. But when it comes to crying, it becomes a sensitive topic, and I often think about why it's not quote unquote normal to cry at work. I would like to share 3 of my experiences with you, each leading to a unique realization surrounding this topic. And I hope by the end of it, we all have some answers for ourselves. As a second-year resident, I was once carrying 7 patients while doing mat nights. One of those patients was an elderly lady with advanced malignancy, and she was made comfort care earlier that morning. Another patient was a transfer from another hospital with septic shock and multi-organ failure. And another one was end-stage heart failure patient. That was a very tough night for me. The comfort care patient, I did not know much about her. It was expected she would not make it through the night. She was the first one that I had to pronounce. Then the septic shock patient, who was, of course, very sick to begin with, but initially she was alert and oriented. She provided me with good history, and I tried to give her some courage and hope to fight this episode. But her condition deteriorated, and her daughter decided not to move her to the MICU and chose comfort care for her. And she also passed away. And finally, the patient with heart failure, I had known him from earlier in this admission. He was a very nice gentleman who used to crack jokes all the time. He also quoted that night and passed away as well. All of this happened in a span of about 5 hours. When I got a moment to sit down and reflect on what had just happened, I immediately knew that I had to move myself to somewhere where nobody could see me. So I rushed into the restroom. I locked the door, turned the faucet on, and I just cried. I could not understand at that point why I was crying profusely, but I just knew that I had to let those tears out. There was a lot going on medically speaking in that moment. Fluid status, cardiac function, renal function, arrhythmias, etc. But there was also a lot going on emotionally in that situation. And I was putting it all aside because I needed to focus on what was more important to me at that time. But I didn't know when that emotional container of mine would reach its limit and things would overflow. After crying, I washed my face, cleared my throat, practiced a few times, just some random words out loud to make sure there was no cracking in my voice, forced to wear a neutral expression, and went back to the unit, carried on for the rest of the shift. I can recall a more recent encounter with a patient of metastatic pancreatic cancer who had presented with a malignant pericardial effusion with tamponade. Over several days that I saw her, I developed very good rapport with her. We connected on her love for playing musical instruments. She was a retired musical teacher. She had just moved to Rochester, bought a new house, and she was planning to live a retired life with her husband and a puppy. But her world got turned upside down by this diagnosis. Unfortunately, she had very grim prognosis. Before she was sent to home hospice, I used to visit her, and she just wanted to hold hands and cry. The last time I saw her, I couldn't help but cry with her. And I apologized to her as if It was unprofessional of me to express my emotions this way, to which she replied that it only made me more human and it made her feel better. The last experience that I want to share is still incomplete. It is ongoing for the last 8 months. Yes, I am talking about this COVID-19 pandemic. It has made me shed tears more than once for more than one reason. Sick and dying patients, unable to meet their loved ones while quarantined, the rising curve of cases and deaths, the constant risk of exposure to COVID-19, the uncertainty that if you get it, what statistic would you become? The exhausting ritual of donning and doffing PPEs and trying to keep your family safe when you could be the carrier of virus to them. These are just a few of the many reasons to fill your emotional container. But here is something that I want to focus on after this. In the few years that I have worked in this hospital, I've seen quite a few staff members cry for one reason or another. Sometimes it is because they feel the pain of the patient suffering. Other times it is just identifying with the patient's situation, or sometimes it is just because of overwhelming, getting overwhelmed by the stress of the job. But what feels strange to me is that almost none of those staff members were doctors, which makes me question if I'm doing something wrong. Are the doctors supposed to be emotionless creatures? Should they not feel the pain of their fellow human beings? Or maybe they all do cry, but they're just doing an excellent job at hiding their tears. Why this fear of tears? Going back to the first story of losing 3 patients in a row, I wonder why I felt uncomfortable crying in front of my coworkers who surely have been in similar situation. What would have happened had I cried there and not in the restroom? Would that be seen as a sign of weakness? Would people point fingers at me next day? Oh, that's the guy who was crying. I doubt I would be the gossip of next day. The second story of the poor pancreatic cancer lady, I asked myself, why did it feel unprofessional to shed a tear with the patient? Is it because I never saw any of my teachers or senior doctors show this kind of emotional expression with their patients? Is there a lack in training? The last experience with the pandemic is slightly different because it also involves us and our families, not just the patients, because we are all at risk. It makes you cry not just for the patient, but for yourself because of the burnout and the uncertainty of this pandemic. I'm sure you all have felt this way at some point in the last 8 months. Why does it feel inappropriate to cry about it? Does it show incompetence? Is it some unspoken code that we are all abiding by? The bottom line is, doctors hide their emotions out of embarrassment, fear of exhibiting weakness, or not knowing how to properly channel them. It is increasingly recognized as unhealthy for doctors to bottle up their emotions. We need to create a culture where it is not just considered natural and acceptable for us to cry, but also there is a support system in place to deal with it without feeling guilty or singled out. Just as we are trained to deal with medical problems, handle difficult situations with patients, breaking bad news, etc., we need to add to the medical curriculum how to deal with such emotions and what protocols to follow when you are at your breaking point. Thank you very much.
Okay, Dr. Aroriode.
Good morning, everybody, and thank you for this opportunity to present at this special edition of Grand Round. It's a privilege and an honor. Humanity in medicine is very vital at this time with all that is going on, and this year has been a year of reflection for me, both in terms of medicine and life. And with that, I would like to go on with my presentation. Two roads diverge in a yellow wood is the beginning of one of my favorite poems. It's by Robert Frost and it's titled The Road Not Taken. It talks about going on a path and then forgoing another, and then contemplating what the other path might have held. In life, oftentimes when I make decisions, I find myself thinking about what the other road might have, where the other road might have led. But in medicine, I don't do that, I rarely do that. I'm quite content with my choice. Medicine, healthcare, and hospitals are a part of my earliest memories. growing up in Nigeria as a doctor's child, Nigeria is a country with vast amount of natural resources and at the same time, access to wealth. But then there's extreme poverty. And I got to see the impact of quality healthcare on lives, be it a successful surgery, optimal medication, or a good counseling session. I could see the joy it brought to patients and their families. And from an early age, I wanted to be a part of it. I basically grew up in medicine. I spent a vast amount of time in my father's practice, from visiting him to actually working there. My first job was there as a receptionist, and I went to medical school. And after graduation, I got exposed to various aspects of healthcare, and I enjoyed all of it. Medicine is my passion, and I believed I had a fairly good idea what it entailed. 2020, however, brought a new dimension to medicine for me. In March of 2020, I found myself in the accident and emergency of the hospital where I spent my first year. I was on my critical care medicine rotation. On my list, I had 38 patients. 35 of those patients had COVID-19, and the other 3 were PUIs. They were all very sick patients. Most had respiratory failure, but then I had some DKAs, PEs, MIs, CVAs, all very sick, mostly intubated. And at that point, it was quite overwhelming. And I got transported back to 2019, watching Avengers Endgame in the cinema. At this point, I'm a comic book fan. And the team was about to go fight Thanos, this super villain. And Captain America was addressing them, and he said, "This is the fight of our lives, and we're going to win, whatever it takes." And I was back in the air, and I was like, this is it. This is not a movie. This is real life. And we're virtually in a fight for our lives against a bug that has caused so much death and so much suffering, and has the potential to cause so much more. But we're going to win this, whatever it takes. And in the coming days and weeks, I drew inspiration from my seniors who picked up extra critical care medicine shifts, from all of my colleagues as we made ourselves continually available to the hospital, even on our days off. And then I thought about all the people who left their families, left everything behind, and traveled to areas experiencing high disease burden to help out. And I realized I could not have asked for better allies in this fight. I stood taller and felt stronger. The world called, and they still call us heroes. Well, many of us have not embraced that title, but we have embraced the role. We put on our capes, roll our sleeves, and we go to work every day, doing what needs to be done. Some days with palpitations, other days with tears, but we keep on pushing on and giving our best. I love movies, but these days I hardly watch any, maybe because I feel like I'm in a never-ending and poorly scripted one. But with my love for movies, I can't help drawing parallels between superheroes and doctors. They mostly all have weaknesses, but so do we. But when there's work that needs to be done, just like them, we stop focusing on the weaknesses and do all we can to save the day. These days, when I wake up in the morning, as I wear my scrubs or my white coat, I pretend I'm wearing a cape or a suit. I try to stay strong and focus on the positives, because this war isn't over and we need each other to beat it. We will beat it. But like I've learned, today it's COVID, tomorrow it might be a new bug or another healthcare problem. But then I believe we will beat that too, whatever it takes. So to me, medicine is more than just a profession. We're here to protect the world from terrible unseen bugs, and we're here to protect the world from and identify factors limiting life and quality of life. With our duty, we help to keep the living going and ensure future generations benefit from all that has been done in the past centuries and are able to contribute to. Right now, we've entered a new phase of this important fight, but we'll beat this and we're going to win. So I just want to say thank you to everyone who gets up every day with fear, palpitations, exhaustion, worry, and just keep pushing on to give individuals, families, and communities comfort, relief, and a reason to have a bigger smile. Every healthcare staff is a hero. And at this point, I think it might not be a bad idea to start to embrace that identity. Thank you for listening.
Thank you, Terry.
As of bringing tears to my eyes here. All right.
Dr. V, you're up.
I would like to share a screen. Are you able to hear and see? Yes. When I was 40, I was very much pregnant, and my obstetrician offered me various tests considering my age. I felt that I could not do anything about the possible life-changing results, and each test made me I made was associated with a lot of anxiety. And at some point, when yet another test was offered, I said, you know, I did my homework, I review all guidelines, went to source material, review recommendations. There is no strong evidence that doing the test can change the outcome. It only makes me more worried. I am the biggest fan of the evidence-based medicine, and I guess I brought up guidelines frequent enough that my obstetricians, understanding where I'm coming from said, obstetrics is not like internal medicine or infectious diseases. There are very little clinical trials out there, very little high quality data available for obstetricians. And I thought, oh, that's true. There are more than 4 million live births in the United States. It is more than heart attacks, strokes, and new cancer diagnoses combined per year. And yet pregnant women are frequently excluded from clinical trials due to complex ethical considerations. More than 90% of medications approved by FDA do not have adequate information on teratogenicity to make the informed decision. As one author put it, pregnancy is an off-label condition. This is a whole specialty out there practicing and deprive benefits of conventional randomized trial internal medicine is so privileged to have. So how do they do this? This was what was going on in my personal life. And at that time, something similar started happening to infectious diseases practice when COVID-19 started. At the time when the pandemic reached the United States, it already was smoldering in China, and Europe already was mitigating the worst damage. And yet, with such a vast experience in other countries and us quote drawing in COVID-19 papers, we had close to none high quality randomized data. In the state of emergency, there was no randomization, but attempts to save lives with whatever tools physicians hoped to be effective. Out of studies registered in clinicaltrials.gov, only about 30% were randomized controlled double-blinded studies, while what is considered low-quality evidence disseminated very rapidly and loudly. Even with this 30%, there are at least two problems. Number one, randomized controlled trials are not free from biases and quality issues. Recent data show that only about 10% of Cochrane reviews are based on high quality data. And the second problem is that clinical trials require time. And with rapidly developing emergency, good quality studies might lose their value the longer it takes for them to bring the result, because so many more people might suffer already. This overwhelming uncertainty in both my personal and professional life pulled the rug out from under my evidence-based confidence and motivated me to reconsider how do I approach evidence. If not randomized controlled trials, if not high quality data, then what? And the first answer was real world evidence. The 21st Century Career Act of 2016 has provisions to examine how real world evidence can be useful. It defines real world evidence as data regarding the usage, potential benefits, and risk of a drug derived from sources other than randomized controlled trials. What are those sources? Well, traditional clinical trials are designed to be separated from clinical practice and to control variability by inclusion and exclusion criteria. At the same time, real-world evidence is coming from routine practice data. This include observational studies, pragmatic clinical trials, various surveillance, and of course, electronic medical records. What helped me to come to terms with not so perfect evidence-based data is realization of just how extremely useful real-world data can be. There are some of the examples of great value of evidence that came not from randomized controlled trials. Number one, post-marketing of phase 4 studies and FDA surveillance. Even the best clinical trials rarely enroll a sufficient number of participants to detect rare but serious side effects with a good degree of certainty. Sometimes several thousand interventions are required to demonstrate a small difference. More than 100 medical products were withdrawn from the market in North America due to reported adverse effects after the launching date based on the post-marketing data. Another example is the surveillance of antibiotics resistance in a community that can effectively dictate empiric treatment. Real-world evidence can be accumulated from big data. Big data means there is so much information out there that it could not be processed by traditional means. Electronic medical records are one of the sources for the big data. Despite the fact that usage of big data is scrutinized for a while, I feel that we have been late in the game. Only imagine with me what would be possible to achieve during this pandemic if all electronic medical records in the world communicated and collected reliable information. Even without clinical trials, we would have unprecedentedly large, accurate, and rapidly collected observational and pragmatic data. Instead, not only we have scattered observational reports from different groups, but the actual big data articles got retracted from elite journals because authors could not demonstrate the veracity of the sources of their data. With all this, however, knowing that your work with electronic medical records can contribute to the vast body of information, that CT10 code you put upon discharge has a potential to become a drop in the ocean of big data, can generate fast, crucial information, brings different perspective and appreciation for electronic medical records. We can rely on real-world evidence in the absence of randomized controlled trial. But what to do if there is no information at all? Dealing with unknown is not formalized in medical education. Modern education expects students to provide the correct answer in the round and the standardized test. But uncertainty is always there as part of the hidden curriculum, and sometimes is suppressed by providers and trainees who worry about their competency. Intolerance to medical uncertainty can have a very negative outcome, resulting in a high level of burnout, stress, and decreased job satisfaction. It might result in avoidance and discomfort while caring for certain patient populations. Why uncertainty affects us so badly? Because we perceive it as a direct threat. But we all have a different tolerance of uncertainty. If you are interested, you can assess yours with a tolerance of ambiguity scale. I'm not aware if it was validated, but I found it very useful for myself to reflect on the statements such as, our most important decisions in life are based on insufficient information. Strongly agree or strongly disagree. Or statements such as, people who insist upon a yes or no answer just don't understand how complicated things really are. Strongly agree or strongly disagree. We all know the classic definition of fever of unknown origin, but the same articles it derived from have a different definition, quite relevant to reality. It defined fever of unknown origin as a source of perplexity and frustration to the physician and anxiety of uncertainty to patients. I do this exercise with PA students. I present a clinical scenario, a real case of a woman who presented with fever, and then I ask the class, what would you do next? After several sensible ideas have been suggested, I say that those tests were done and were normal. Meanwhile, patient continues to suffer from fever, lack of appetite, and anxiety. And I ask again, so what would you do next? After a cycle of good but fruitless idea repeated again and again, and nothing reveals the cause of the illness, and I keep saying the patient still has fever, losing weight, and now she's getting really upset about everything. So what would you do next? Eventually, students have a moment of realization what frustration and anxiety of uncertainty really is in clinical practice. When we discuss some tool we used in management of undiagnosed conditions, such as sharing decision-making with patients, empiric treatment versus observation, or recipe book approach. In this case, the patient was eventually diagnosed with renal cell carcinoma through a full reassessment, a temporal repeated renal scan, and underwent successful treatment. But in the end of the day, it is important to accept uncertainty as part of our reality. It is a part of what our world is. Uncertainty is unavoidable and undeniable, and we should normalize it rather than think of it as a failure of competency that needs to be suppressed or as a threat that evokes anxiety. Uncertainty would better be perceived as an opportunity to improve our life, an opportunity that would rather be met with curiosity of explorer. Thank you.
Thank you, Dr. B. Dr. Bhavsar.
Good morning. Thank you everyone for joining and for allowing me to share a brief moment of reflection. I tried to think through about all the different ways that we can share thoughts about the practice of medicine. I know this is something that I've tossed around in terms of what does it mean to practice medicine, whether it's clinical or whether it's through other ways, and what does it mean to be in healthcare and the places in which we work. And so I hope to share some of those thoughts with you today. There are very few professions where complete strangers will share intimate details of their minds, their bodies, and souls without hesitation. Few professions where we may know more about a person's life than their own family or loved ones, where we may be the first sight at birth and the last at death. Like the field of medicine, the places where it is practiced equally create a sense of safety, protection, and community. The memories that are created in the halls where medicine is practiced are just as meaningful as the practice itself. The first time I ever walked into the hospital, I was 14 years old. It was summer break, and I was told by my parents that I needed to volunteer if I wanted to be a doctor someday. My mother used to work in the daycare across the street from the main hospital in downtown Dayton, Ohio. I signed up as a volunteer, not knowing what to expect. The uniform at the time was simple: a red shirt, khakis, and comfortable shoes. I still own that red shirt today, a simple red shirt with the word MVH volunteer on the top left corner. On my first day, I remember walking from the daycare and into the hospital. My sneakers tied, khaki pants, and my red MVH shirt tucked in. I can still hear the sound of my shoes hitting the pavement as I walked along the long, gritty sidewalk, slightly uphill towards the main entrance. The sound of automatic doors opening and the cars idling in the turnabout, anxiously or patiently waiting. I walked through the revolving doors into a crisp, clean marble lobby and instinctively looked up for a sign pointing me where to go. I remember the smell, a cool medley of ultra-filtered air, cleaning solution, hand sanitizer, and people. But I felt like I found my place, a new home away from home for the summer. My first assignment as a volunteer was flower delivery. I remember walking into a patient's room for the first time, the medicinal smell, the linens, clear tubing of medicine, body fluids hanging in bags, and here I came with fresh flowers and a smile. Patients saw my uniform and knew my role. They welcomed a nerdy 14-year-old holding flowers from a loved one or friend with well wishes. The nurses and doctors would hurry past in and out of the room, and so most patients assumed I was part of the team. My next assignment was in the PACU, providing warm blankets and water as patients were wheeled in to recover after surgery. Some of them shivered, some snored and drooled with looks of pain or sometimes relief. Some grabbed my hands and others just wanted to be left alone. I went on to spend several summers, close to 40 hours a week, while my mother worked at the daycare volunteering. But throughout that time, I never wondered why people allowed me to come into their room, give them warm blankets, refill their water pitchers, or deliver flowers. They let me help them cover up for privacy or asked me to close the door when they needed some time alone. But they never questioned my presence. I was part of the team. I was there to help. My second distinct memory was my very first day as an intern, June 29, 2009. This time, the uniform was a little more complex. A black shirt, tan pants, comfortable shoes, a white coat with my name and credentials on the top left corner, a stethoscope, and a pager. I reported to the third floor of the Cleveland VA Medical Center on the Blue Medicine team. This was our first day, so we were going to round together as a team. While on round, suddenly, a now familiar, loud, alarming sound called my attention. I pulled out my pager, saw the 4 digits listed, and found a phone. It was in a hallway away from my team. The nurse on the other end conveyed a confident urgency about a patient having chest pain and asked, "Is someone going to come soon?" I responded yes, paused, and hung up the phone, only to realize I made the rookie mistake of forgetting to ask where the patient was. Eventually, I found them on my list. On my way to the patient room, I pulled out my pocket medicine book for a quick refresher on evaluating chest pain before walking in the patient's room. I asked more questions than I needed to. The patient, an unfazed veteran in his 50s, answered them willingly. I'm sure he saw on my face expressions of fear and inexperience compete with attempts to appear confident and competent. Nevertheless, he didn't stop me. He let me ask about every detail of his pain, his family, whether they were dead, if so, when and why, and all the while experiencing the very pain I was eager to understand. He let me ask him about his medical history, his vices, his hobbies. I finished my interview and walked and awkwardly examined his heart, lungs, abdomen, legs, head, and neck. I presented my findings to the team. We formulated a plan and treatment and went on to the next patient. As I continued through training and eventually as an attending, I continued to walk in and out of patients' room with increasing confidence. None of them stopped me or questioned my purpose for being there, even at odd hours of the day. The patients answered my questions, let me examine and intervene on their bodies without hesitation. They allowed me to interrupt phone calls, conversation, share laughter, and tears. They were in a safe place, and we were there to help. They did so in Cleveland, and they do so here in Rochester. There was no difference. My uniform, not too different from what it was back then. The sights, sounds, and smells also all too familiar. More recently, I had a chance to tour the Sands Constellation Center for Critical Care before it opened. July 31st in the afternoon, it was a beautiful sunny day outside, not a cloud in the sky. The uniform, a mask because of COVID, hard hat, reflector vest, safety goggles, and comfortable shoes. This was my very first time ever seeing the building. We walked up a small plywood ramp, up the stairs, careful not to touch the railings with fresh paint, and made our way through the building. The smell of paint, varying shadows from the natural light and newly installed fixtures, a floor scattered with construction debris, sound of carts moving materials about, tracks of pipes for air, gas, water, ventilation, carefully sneaking across the ceiling, but with a clarity of purpose. I was overwhelmed. I remember thinking at that time, in just a few weeks and months, perfect strangers will come and meet in this new place. They will walk through the halls with a mix of emotions and purpose in their steps. They will be moved around the hallways through shadows and brightness of the natural light and fixtures that were being placed. They will allow us to ask them about the most intimate details of their lives. They will let us examine and intervene their bodies without question, hesitation, or pause. They will allow us to interrupt precious moments and need us to burst in to save a life. Patients and team members will make new memories here, happy ones, sad ones, important ones, memories they will keep forever, and some they'll want to forget. They trust that this place was built to help. They trust that the people coming in and out of the rooms, the uniforms in varying colors, badges, pagers, and phones are all here to help. The lights, sounds, and smells and textures may be cemented in the memory for years to come for many patients and team members who walk through our halls and our lives. In medicine and healthcare and being a doctor, the practice can be just as memorable as the place. The foundation for both is the same, one of trust, a sentiment that's embedded in the spoken oath we take as physicians and the unspoken trust we must uphold. Thank you for letting me share this reflection.
Thank you. Wow, those were some moving presentations. I saw that Kay Wahl raised her hand, and I'm going to ask, let's see here, if I can find a way to unmute her so she can say something. Kay, would you like to say something? In the meantime, I do want to remind people that numbers in the community are popping up. I know it's the last thing we want to hear, but in the last week, the slope of the increase in numbers is quite striking. It's the kind of slope that precedes another significant surge. We've seen several people, staff members, physicians, et cetera, go out with positive tests. For the most part, patients are not the source of this. So if you use appropriate PPE, it works. Most of these staph infections have occurred due to staff congregation or community spread. So be very, very careful with your social distancing, especially in the next couple of weeks, because we are seeing another surge. I think Nadine is on and unmuted. Please go ahead.
Well, good morning, everyone. And I want to thank you very much for the very thoughtful comments and reflections that everyone shared today. It's significant to me that you're doing that in Gary's name, as you all knew him in a clinical setting. I only knew him at home. And I can tell you he was that same thoughtful, kind, generous person, funny, silly, calm, always calm at home as he was at work. And this is a difficult time. I don't know, the girls and I have talked about it. Lindsay, who's an anesthesiologist, his youngest daughter, feels certain that Gary may have gotten COVID. And with his sarcoid lungs, he might have been gone anyway. I can't imagine what it must be like for all of you to have to go to work each day and face all the things that you have to face and work so hard and diligently in the face of this terrible pandemic. So I thank you for that, for your bravery, for your courage. And as I mentioned, I sent a little note. Years ago, Lindsay had made Gary a Mr. Incredible costume. He liked to dress up for Halloween for the kids coming to the door. And so we always thought of him as Mr. Incredible. And I think of you guys as Dr. Incredibles, because the work that you do is so important. So sometimes in this political climate may be unappreciated, or we forget, right? We forget that who's holding the line, the nurses, the staff, the doctors and all those things, but I don't forget. So I wanted to thank you for that and for this wonderful memory that you're providing for him. Thank you.
I think this is certainly appropriate in his honor, because he will always be remembered for his humanity as a physician at the bedside. The people who will thank him forever are his patients who received care from him. Thank you all. Anyone else for comments? I'm looking at the chat box. I'm looking at the Q&As. I think we're out of things here. So we're, any closing comments, Gabby, or? All right. Well, thank you all. This was wonderful. And thank you to our 4 panelists. I know this is not easy to do, to sort of lay it out there with emotions and how you're feeling and sharing all the tears, and it's not easy, but I think it's a useful exercise, and it's something our younger faculty and students and residents need to learn, that medicine is not a profession like any other. It's a calling, and once you're in it, you're in it for life, and you need to be committed to it to get everything you can out of it and to give back. So thank you very much, and see you all next week.